this is what we're going to cover that I have on my agenda, okay? We're going to go over the anatomy of the shoulder. Is my voice good? Yes. So we're going to go over the anatomy of the shoulder, which I think is the key to understanding some of the words and terms that I talk about, because you have to know a little bit of the anatomy. And these are the causes that I'm planning on talking about. And rotator cuff disease can be caused by, I've seen it after a pneumonia shot. I've seen a frozen shoulder after breast surgery. Arthritis can be caused from trauma, or you can be born with it and it slowly worsens over time. Biceps tendon disease is usually a repetitive use problem, and fractures are from falls. So first we're going to talk about the anatomy of the shoulder. This is looking at the back of a right shoulder. You can see the shoulder blade called the scapula sitting on the rib cage, and you can see the arm bone called the humerus meeting the scapula at the glenohumeral joint. The joint between the scapula and the rib cage is called the scapulothoracic joint. The thorax is where your ribs are. And then on top there's another joint between the clavicle and the top of the shoulder blade called the AC joint. And the top of the shoulder blade is called the acromion, so we call that the acromioclavicular joint, or AC joint. But where we're going to really focus is mostly on the glenohumeral joint, which is affected by a frozen shoulder, rotator cuff tears, the fractures we're talking about. And what's important to know, particularly with frozen shoulders, is also the scapulothoracic joint, which is not affected in the majority of shoulder cases, but is important for physical therapy and rehab. So first of all, we're going to start with the little joint up on top, the acromioclavicular joint. This is a bird's eye view looking down onto a left shoulder. The top of the shoulder blade is called the acromion. The clavicle meets it at the joint. On the right-hand side, there are some ligaments. And we're not going to spend a whole lot of time on this joint today just because of time, but there are ligaments that connect the acromion and clavicle together that tear when people separate their shoulder. They have a fall on top of their shoulder, usually seen in athletes or people who have bike injuries, slip on the ice, and you x-rays are normal, but you're painful right on the AC joint. Usually doctors will say you have separated your shoulder, you've torn some of those ligaments, because the ligaments don't show up on x-rays, only bones do. Inside the shoulder, if we look at the socket, it is somewhat pear-shaped, and this is a view of the socket. You can see the acromion, which I'm going to keep coming back to, is again the roof of the shoulder. And in this view right here, you can see the acromion is somewhat flat in shape in nature. It kind of goes straight across, but sometimes it has a hook or curved configuration. But this picture right here, sticking to the anatomy, is showing a picture of the labrum, which is a rim of cartilage surrounding the socket. And this labrum gives stability to the ball and socket joint, which is very similar to a golf ball and a golf tee. And people refer to the labrum as a little bit like a chalk block, like you'll see put in front of a tire of an airplane to prevent the airplane from rolling. This little labral bump kind of prevents the humeral head from rolling off the socket. Also helping with stability, keeping the ball and socket together, are the ligaments. And there's three major classes of ligaments: the superior, the middle, and then the inferior ligaments. And these ligaments are typically torn and disrupted in young people, teenagers, 20-year-olds who have dislocated shoulders. As we age, our ligaments become stiffer. We have more cross-linking of our collagen fibers as the sulfur bonds increase. So there's a real reason why we get stiffer with age. And that's why it's unlikely to have people with recurrent shoulder dislocations over the age of 40, but it's more common over the age of 40, 50 to have people ripping and tearing things like rotator cuff tendons. The muscles of the shoulder, as we go a little superficial, there are really two major superficial muscles. The biggest one is called the deltoid. There's three parts to it. And the other one to the left of the big cephalic blue vein in the middle of the picture is called the pectoralis major. And if we go deep to those muscles, we will get down to the rotator cuff tendons, which are, admittedly, for someone who worships rotator cuff muscles, I admit they are rather wimpy. and they are injured quite frequently. So the four muscles each have a name, but together they form a cuff of tissue. And sometimes people say, did I injure my muscle or did I injure my tendon? The muscle is the fleshy part over here. If I were to take a knife and cut this muscle over here, it would heal. People invariably injure the tendon, which has poor blood supply. So it's usually the tendon that rips off the bone. So you can have, a rotator cuff muscle strain, or you can have a rotator cuff tendon injury. It's the tendon that gets injured, but we call these group of muscles together rotator cuff. So when people say, I injured my rotator cuff, I usually say, which muscle? Because it's important for me as a surgeon or doctor treating these injuries to know exactly what I'm treating. But you'll hear people say supraspinatus. I tore my supraspinatus, which is the most common rotator cuff muscle injured. And then you hear other people say, I had a rotator cuff surgery, which is kind of a vague term to use. I'm not really sure what that means. I had rotator cuff surgery because maybe it didn't need to be repaired. But those are the muscles we're talking about. And the function of the shoulder is really a battle between the deltoid and the rotator cuff muscles. And this, to me, is the take-home message, and I put these slides early in the talk before you fell asleep, because if you want to know really about the shoulder, these next 4 slides or whatever, really, or next 5 slides tell you everything. The deltoid is a beast. It is the biggest, strongest muscle. It never gets injured. That's where your pneumonia shot goes. It is innervated by C5, the same innervation that goes to your rotator cuff, so perhaps the pneumonia shot goes into the deltoid and causes inflammation, which leads to then secondary rotator cuff pain syndrome type, but I know of no literature out there that talks about how a pneumonia shot or any shot into the shoulder deltoid causes rotator cuff injuries or problems. But I have seen a lot of people who get a deltoid shot, pneumonia or anything, who then present to me 2-3 months later saying my shoulder still hurts, and they've developed now kind of classic rotator cuff symptoms. I don't know if it's because of irritation of the C5 nerve, which is the same nerve that goes to the deltoid and the rotator cuff, or whether the injection weakened the deltoid and it made whatever subtle injury there was to the rotator cuff more prevalent. So I really don't have a good answer, but I've seen a lot of people, not a lot, maybe one a year over the last 15 years, that's a number though, who come to me with shoulder pain after a shot. So the deltoid's very powerful, rarely gets injured. It is always trying to lift the arm up into this direction right here. And if you only had a deltoid, my arm would do this. So you need something to keep the arm down into position to allow the deltoid to pull the arm all the way up. And that's your rotator cuff muscle. So if you look at the vector, if you look at the alignment of the rotator cuff, you'll see the subscapularis is kind of pulling in an inferior direction slightly. The supraspinatus up on top, when it contracts, it sucks the ball into the socket. And the infraspinatus and teres minor in the back, again, you can get a little appreciation that those fibers are also heading a little bit in a downward direction. So the rotator cuff muscles are keeping the ball down so that the deltoid, when it fires, causes the ball to pivot on the socket as opposed to coming up out of the socket. So this is an MRI. This is an MRI of a normal shoulder, again, a left shoulder. You can see the ball and socket. This is the humerus right here. This is the socket right over here. Our friend the acromion is right up top here. And coming off the acromion is a dark muscle called the deltoid. That's the deltoid. It's coming all the way down here. And the deltoid comes all the way down, and it's going to insert halfway down or a third of the way down the arm. This white stuff here is fat that's underneath the skin. The white is the marrow that is filled with fat. So the dark structures are the muscles. This dark structure is the supraspinatus. So that right there is the supraspinatus tendon inserting normally where it's supposed to insert. And when you have the deltoid and the rotator cuff acting normally, the deltoid tries to lift the arm up, and the rotator cuff is sucking the ball into the socket. And you have a nice space. Everything, the humeral head is kept nice and low. This indicates the space between the acromion and the humeral head is preserved. That space is filled with the muscle. And also this line right here is pretty much telling you that the bottom of the humeral head is pretty much at the same level as the bottom of the socket. Now in a rotator cuff tear, there's a problem. That's the rotator cuff tendon right there. That's the edge of it. That's the supraspinatus edge. It is supposed to belong over there. It is torn and retracted. When the deltoid fires, it pulls the arm up, and without a rotator cuff working, you have the humeral head rubbing against the acromion, and you have kind of this broken line down here. And that's why people with rotator cuff tears are like this. You know, they're miserable and stuff like that. All right, so that's the take-home message. So let's just give you a little bit of what a normal shoulder. I know you all just ate. If you want blood, I can show you pictures of blood at the end. This isn't terrible. So this is a normal shoulder. We're coming in from the back of a right shoulder. The socket is to the left. The biceps tendon is up on the top. That's a little cannula. It's the shape of a straw. And through that cannula, I can put a probe and I can touch the labrum up on top. These cannulas and cameras that I use are essentially the same size of a pencil. I can pull on the biceps tendon to make sure there's no tears in it. Everything is nice and white in this normal shoulder. The cartilage on the ball and socket are nice and white and smooth. The labrum in the front is normal. The tendon in the front of the shoulder was the subscapularis tendon, which is underneath the cannula. That's the subscapularis tendon we're looking at right there. I want you to appreciate how thin, I don't know if I show you in this video, but the ligaments are very thin. That's the subscapular. Coming over from the northwest or upper left is a little ligament draped over the subscapularis. That's how thin these ligaments are. Here's the supraspinatus tendon inserting on top of the humerus from up above, nice and normal. So that's what we like to see when I go into a shoulder joint. That person had a normal shoulder joint, but the pain was coming from above the shoulder joint between the acromion and the supraspinatus. So I kind of think of the shoulder like a two-story townhouse. The first story, one wall is the socket, the other wall is the humeral head, and above is the rotator cuff tendon, the supraspinatus. And then I go up onto the second floor where the acromion is up above and the supraspinatus is now the floor. And in that space, it oftentimes is filled with bursa, which I'm going to show you. And sometimes the acromion can have a bone spur digging into the rotator cuff, which I'll show you as well.
Thank you.
All right. So let's go talk about rotator cuff disease right now. A lot of terms you'll hear. You will have the same patient that will go to 3 different doctors, and one doctor will say you have impingement, another will say you have tendinitis, another will say you have bursitis. All 3 of those are kind of essentially giving the same description to somebody who has pain when they lift their arm up, pain when they put their arm into a jacket, good range of motion, but pain with sleeping on that arm and with overhead activities. That's all kind of rotator cuff disease. Rotator cuff disease will typically present, this is the presentation. We talked about the acromion can have a bone spur. This is an example here, this picture where the acromion is nice and flat, but there are some people who have gentle little curves, which we call a type 2, or a sharp hook, called a type 3. And many times I will see somebody and I'll see their x-rays before I visit them and I say, ooh, I bet you they have a rotator cuff problem because they have a prominent bone spur underneath the acromion. So the bone spur will dig typically right onto the supraspinatus tendon, and I think that's why the supraspinatus is the most common source of rotator cuff problems in the shoulder. Again, another little picture. So this picture here on the left kind of shows you this is the space where the supraspinatus tendon resides and muscle. It resides underneath the acromion. So if you have a large bone spur digging in, then you have that bone spur kind of pushing into the supraspinatus, causing pain whenever you lift up your arm. There's a tissue all throughout our body that's normal called bursa, depicted here in blue. Bursa is a slimy tissue. It is designed to allow 2 surfaces to move against each other. We have bursa between the skin and our elbow bones right there that can get banged and inflamed, and you may have some friends who have swollen olecranon bursas. But you can also get bursitis, or inflammation of the bursa, between the acromion and the rotator cuff tendon. So again, it would present with pain in that region, very similar to what impingement presents with. And tendinitis is inflammation of the rotator cuff tendon. There are certain activities that will aggravate rotator cuff problems, and those are repetitive overhead lifting. So I tell my patients, don't do push-ups, don't do bench press, don't do pull-ups, don't do military press. And these are all activities that can aggravate the shoulder. So how do I treat somebody who comes into me saying my shoulder hurts and I think they have rotator cuff problems? I give anti-inflammatories. I will give a cortisone injection. So usually people come to me and say, I've been trying Aleve, I've been trying ibuprofen, but I will give cortisone injections. Cortisone, in my mind, is wonderful. It has 3 misperceptions. Way back when, there was a study that when they gave massive amounts of cortisone to a little mouse ligament, it showed that it weakened the collagen. So I do believe, and as most people believe, that cortisone, if you give it in high doses, will weaken tissue, and that's true. So I have people come to me and say, I don't want a cortisone injection, and I'll say, why not? And they say, because it destroys the tissue. And I'll say, if I give you lots of cortisone, it will destroy the tissue. It's like, I don't want to take Tylenol because it will destroy my liver. If you finish the bottle of Tylenol, it will destroy your liver, but if you take 1 or 2, it won't. Try 1 cortisone injection, it will not destroy any tissue. And I will give cortisone injection 2-3 times a year. I will try it once. If it doesn't work, I don't do it again. If it works for 6 months, I'll repeat it. If I've given 2 or 3 of them and the pain keeps coming back, I will say, go to the next step. Oftentimes when somebody comes to me for a cortisone injection, I will refer them to physical therapy. The goal of physical therapy is to make sure the shoulder is not getting stiff and also to improve the strength of the rotator cuff and the muscles around the shoulder without aggravating by doing those exercises I just showed. And surgery is the last resort. So these are different anti-inflammatories. Over the counter, I think it's fine to start with ibuprofen, which is the same as Advil or Motrin, or Aleve, which is the same as naproxen. Some people have stomach upsets and do better with Celebrex. That's fine. There's literally about 20 different anti-inflammatories out there, and you just try to see if you find one that works for you. The steroid injections, I told about the 3 misperceptions. One is that it damages tissue. I think if you abuse it, it damages tissue. The other misperception is that it's temporary. I've given cortisone injections to people before and they've come back 2 years later for their other side. So I think it can be more than just temporary. I think it can be curative. It can be temporary, but because I've seen long-lasting pain relief, I try it. And the third misperception is that it masks the pain so you can do more damage to the shoulder. And that is not true. That's what Novocaine does. If you were to have an injured something in your body and we injected it with Novocaine, you were like, wow, the pain's gone, and you started walking on a broken ankle, yeah, you could do more damage. And that's what happens if you ever watch football games, particularly in the playoffs or the Super Bowl, and you see a player walking off like this, and then they come back out of the tunnel 10 minutes later jogging onto the field. They've gotten an injection of Novocaine, but they're playing in the Super Bowl. So, who cares? They'll deal with what happens afterwards and stuff like that. But cortisone does not mask any problems. It decreases the inflammation. I think of it as a 3-step process. Something, whether it's a bone spur, swollen bursa, or arthritis or something, is causing inflammation. So something is the first step, causing inflammation, which is the second step, and the inflammation is causing pain. The cortisone decreases the inflammation, so the pain goes down. How long will it take for the something, the cause, to cause the inflammation to come back? I don't know. Sometimes years. Yes?
I'm very highly sensitive to steroids. Is cortisone an anti-inflammatory steroid?
Mm-hmm. It is. There are different anti-inflammatories. There's non-steroidal anti-inflammatories like the Motrin and the Aleve. And then there are steroid anti-inflammatories like cortisone or prednisone. And physical therapy, again, designed not to aggravate the shoulder, but to strengthen the muscles, typically the upper back muscles. These are good exercises to do, keeping the arm below the shoulder level. So anything up here is going to aggravate, but things down at this level, internal, external rotation, and particularly rowing exercises are particularly good for the strengthening the upper back and improving the mechanics of the shoulder. Here's a surgical treatment when somebody has had cortisone, somebody has had physical therapy, and continues to have pain. We are right now looking in the back of a right shoulder with the acromion up above and the rotator cuff tendons down below, and this cotton candy type tissue is bursa. The bursa should be as thin as a strand, one sheet of saran wrap. So this is very thickened, inflamed bursa that was causing this patient's pain. And this little device is coming in from the side of the shoulder. Again, it's a size of a little pencil. Everything's kind of magnified. So there's 3 little incisions. The camera's coming in from the back, the little shaver's coming in from the side, and that little straw in the front, you can see kind of in the front of the picture. Now that I'm getting rid of some of the bursa, you can start to see the white tendon of the rotator cuff appearing underneath. And there's no rotator cuff tear in this patient, so it's going to look nice and like a white tendon. If there was a tear, we actually would be able to look right into the shoulder joint. We'd be able to see the socket, the ball and socket, which is never a nice thing to see. So this is a patient that had bursitis as well as a bone spur. We're going to get rid of all the bursa here. This is a procedure that takes maybe about 25 minutes to do, cleaning out the bursa and shaving down the bone spur. Whenever I do a rotator cuff repair, I always do this first. So we clean up the shoulder, get rid of the bursa. Now we're looking from the side, and you can see the acromion has that little curved configuration, and this is a high-speed burr, again the size of a pencil, coming in, and we are going to flatten out that little bone spur so hopefully it won't dig into the rotator cuff tendon. The surgery is done underwater, so it prevents bleeding, but that's why it kind of looks like this.
Will a bursa ever repair
Yeah,
itself?
yeah. So new bursa forms back. Wherever you have 2 surfaces, it will form again. So normal bursa will recur. But, if let's say this patient is 50 years old or whatever, my thought process, maybe it'll take another 50 years for it to become that bad and stuff like that. And maybe it became that bad because that person did a lot of overhead activity, and if you just protect the arm. So usually we don't have to operate and remove the bursa again.
So you completely removed the bursa? Or did you just clean it? You
removed it.
And it grows back?
It will grow back thin like a ceramic. The next step in rotator cuff disease, besides bursitis and tendinitis and impingement, is if the tendon is torn off the bone. And this is where I will say when people come to me with tendinitis, bursitis, impingement, I usually treat people non-operatively as best as possible, because it doesn't matter if I operate on them now or 3 years from now. See if you can live with it. But when somebody has a rotator cuff tear, I get nervous because these tears can get larger and the shoulder can start coming up out of the socket. So the most common reason for me to recommend surgery is a rotator cuff tear. This is an example where on the left the tendon is detached off the bone and you can look right into the joint. This being the edge of the tendon right there. It's supposed to be down here. And the picture on the right is after I've sewn it back down. So give you a little bit of an idea of how we do this. And if anybody says, stop, I can't take this anymore, although I think it's beautiful. So that's the supraspinatus. There's a hole in the supraspinatus tendon. All right, I'm actually bringing that. I'm not supposed to be able to go right through the hole like that. This is a little gross. I apologize, but this kind of gives you a little idea of the poke holes that we use. Right shoulder. The front is to the right. The back is to the left. We'll go back into the back of the shoulder. I think that's the last kind of gross thing I show. This is a little device we use at surgery. It uses radio frequency energy. It helps get rid of the the tissue as well as the shaver. And what's nice about this is that this will help stop any bleeding so that I can see what I'm doing. So I'm cleaning up underneath the acromion. Getting rid of the bursa. There's a little curve to the acromion up above, and here's the hole in the tendon that we're going to want to sew back down. You shouldn't be able to go right into the joint. The 2-story townhouse has a hole in the first floor. Removing the bone spur. Flattening it out. And then we add anchors, and you can do this with an open, making an incision, or you can do it arthroscopically. There's no difference as far as results are concerned. I find it a little more comfortable for patients if it's performed arthroscopically. So that's what I do. I also feel in my hands I can do a better job arthroscopically, where I can take the camera and zoom all around the shoulder joint as opposed to making an incision and having to work through the incision. But we put an anchor, which is like a little harpoon into the bone, and coming out of the anchor are suture materials. This device is called a penetrator, pretty aptly named. It penetrates through the tissue and can grab the suture material. And we do this a few times, penetrating the tissue until the sutures are through the tissue, and then we can grab the sutures and tie a knot, and it will bring the tendon right down onto the bone. To put the anchors into the bone, typically we will punch a hole into the bone. Some anchors, like the first one you saw, are titanium, which is okay for an MRI. Others, like this next one, are bioabsorbable. And then a third class is PEEK, which stands for polyether ether ketone, and is a medical grade plastic. And I typically will use the PEEK. There are some that are also biocomposites that will absorb into the bone, but those are just extraordinarily expensive and don't really offer a tremendous benefit. So this is what it looks like after it's been repaired. The acromion's been flattened out, the bursa's been removed, and the rotator cuff now is sewn back down onto the top of the arm. And if you looked from the joint, looking up, instead of seeing a hole in the ceiling, it's now been plastered back down.
So do those sutures just dissolve?
Those sutures do not. Yeah, they stay there. They actually overgrow with a little bit of tissue, so you oftentimes don't even see them. Sometimes people will say my shoulder clicks after surgery, which may be from the sutures, but the clicking is oftentimes painless. We have used absorbable sutures. Everybody heals differently, and the sutures absorb at a rate. So if somebody's tendon needs 6 months to heal, and the sutures dissolve at 3 months, it will re-tear. So we use now non-absorbable sutures, and people do not seem to have issues with that.
Is there a classic diagnostic symptom for rotator cuff tear?
Yeah, when I have students that follow me, the rotator cuff problems in of themselves will classically be pain with overhead activity, pain sleeping, pain reaching behind my arm, okay? For a rotator cuff tear, to differentiate rotator cuff tendinitis from a rotator cuff tear, I have people hold their arm up like this, and I press down on their forearm. If it's tendinitis, bursitis, or impingement, they'll say, yeah, that hurts, but they can kind of fight me. Maybe some people are a little weaker than me, maybe some people are stronger than me, maybe I can push them down with 2 fingers. They'll say, yeah, that kind of hurts. With a rotator cuff tear, their knees will buckle. When I do this right here, they'll go, ugh, and I'll say, ooh, I think we should get an MRI, because I'm concerned.
Thank you.
So how to avoid rotator cuff problems? Avoid repetitive overhead work, because that stresses the supraspinatus. Avoid over-the-shoulder level weights, so bench press, military press. And keep the upper back strong, the rhomboids, the lower trapezius, the serratus anterior. We're going to talk about frozen shoulders now. A stiff shoulder is a painful shoulder. So even if everything is looking perfect on the x-rays or the MRI, and many times I will see somebody with a frozen shoulder who comes to me as a second or third opinion saying, I have pain, and everybody says my shoulder is normal because the MRI is normal. But a stiff shoulder is just as painful, if not more, than a rotator cuff tear. And the stiffness comes from inflammation of those little ligaments that we talked about at the beginning. And for whatever reason, open heart surgery, breast surgery, radiation are all things that can lead to inflammation of the ligaments and a frozen shoulder. Classically, people will have pain, more common in women. People with diabetes are more susceptible to a frozen shoulder, most classically seen in the 40 to 60-year-old age range. A stiff shoulder over the age of 60 will oftentimes have arthritis as a component. Unless somebody has had breast surgery or radiation, then that can be the cause. So there are only three things in my mind that will cause stiffness and loss of external rotation. One's a frozen shoulder, the other's arthritis, and the other's a dislocated shoulder. So I usually get x-rays on people, and I can rule out the arthritis and the dislocated shoulder. If the x-rays are normal, it has to be a frozen shoulder. So to treat the inflammation, we want to stay as flexible as possible. Many times people will injure their shoulder and put it in a sling thinking we'll protect it, let nature run its course. That's actually a good way to get a stiff shoulder. Anti-inflammatories and physical therapy will help decrease the inflammation, and physical therapy will help you stay loose. And then surgery. So little exercises that can be done. On the left, we call these pendulum exercises, letting your arm act like a pendulum of a clock. On the right, little exercises that can be done sitting, putting your arm up onto a table, leaning down like this, using a towel or a cane to assist in moving your shoulder, and then physical therapy. And the physical therapy has to be manual physical therapy. And the reason why is that the joint that is stiff is the glenohumeral joint, the shoulder joint. But you still have the scapulothoracic joint, which is not stiff. And if you just go to the corner and do exercises on your own with TheraBands or pulleys, your stiff shoulder joint won't loosen, but your shoulder blade, the scapulothoracic joint, will do all the work. And people with stiff shoulders say, I've been going to therapy, I've been doing the exercises, and I'm not getting any better. It's because they're not using their shoulder joint, they're using their scapulothoracic joint. So you need somebody manually to hold the shoulder blade still, and then stretch out the ball and socket joint. So non-manual therapy, massage, I don't think ultrasound helps. I don't think pulley exercises help. It really needs to be manual therapy, mobilizing the glenohumeral joint. This is an example of a normal shoulder on the left and a frozen shoulder on the right. On the right, appreciate how thick the ligaments are that I'm cutting in a frozen shoulder, and you can see how red and inflamed it is. On the left, the probe is about to touch one of the ligaments. You can see through it. It's such a flimsy normal ligament. That's how thick a normal ligament is. It's like saran wrap. And on the right, you can see how thick it is, almost a centimeter thick. That's the muscle underneath the ligaments once I get through. So how to avoid a frozen shoulder? Stay flexible. And if you get injured, just be in a sling for maybe a week or two, but then come out and really think about staying as loose as possible. Because a stiff shoulder is painful. Motion is lotion. The next thing to talk about is arthritis. This is a gentleman who's had both his shoulders replaced. So what exactly is arthritis? In the joint in that normal videos, we show that the ball had nice normal white shiny cartilage. This is where that cartilage is missing. When you are missing the cartilage and you're down to bone, that's arthritis. The analogy I oftentimes use, it's not an analogy, well, I guess it is. If you look at a chicken leg, the white shiny stuff over the knob of a chicken leg, that is the cartilage. If you take a fork and you scrape off that white shiny stuff, and you get down to the bone, that's the definition of arthritis. The loss of the cartilage that's on the ball and socket is arthritis. So on the left, you have a normal shoulder with normal cartilage on the ball and socket. And on the right, again, you have an inflamed red, something's wrong with the shoulder, arthritic shoulder. As I pull back, you can see the labrum on the right, the biceps tendon insertion is all kind of frayed, but here's the cartilage on the back of that shoulder. It's just all ripped off, and you're down to the bone.
Does it just wear away over the years?
Yeah, the most common is just wear and tear, osteoarthritis. The cartilage can be eaten away by your own body, where your body attacks the cartilage. That's rheumatoid arthritis. And you can develop arthritis after a trauma. If you fracture through the cartilage and it doesn't heal properly, oftentimes it doesn't, you'll get arthritis.
Is there potential for stem cell therapy of the shoulder?
Yeah, there are still in nascent stages, which has been for the treatment for arthritis, like what can we do besides replacements and stuff like that? You can harvest cells, grow them in the lab, and particularly if you have a defect like that, what we call a focal chondral defect, you can actually inject the cells into that defect and hope that it fills in, because the rest of the joint is normal. You can actually take a dead person's cartilage and a plug of cartilage and bone and plug it into that. So those procedures have all been done as far as, but when the arthritis gets to be kind of like in this video where it's so diffuse, it's on both sides, what we call kissing lesions, it's both on the ball and the socket side, then those cartilage restoration procedures are not very helpful.
Do you do any of it?
I don't, but we just hired a new guy. I'll put a pitch out for him, a guy named Tyler Welch, who has been just trained out in California in cartilage restoration procedures, which is very exciting, that he can bring that technology to this area, because typically to do that type of procedure, which isn't done that frequently, you have to go to a major medical center, and hopefully Tyler will give a talk on that. What he's bringing to this area is not just cartilage restoration, but also hip arthroscopy, which not too many people do. It's usually also an academic center, but hopefully he will be giving a talk on those topics shortly. Sorry to put pressure on you. All right. So this is x-rays of what an arthritic shoulder is. On the left, you have a nice normal space. On the right, the space between the bones is gone because the cartilage has worn away and you're bone on bone. You can even appreciate it in the little AC joint up above. Maybe hard to see on the right side, but you can see a normal space on the left, and on the right, the cartilage has worn away, you're bone on bone. The bone is alive. It has blood supply. The cartilage does not have blood supply, so the cartilage cannot heal itself, and that's the problem. When the bone senses extra pressure, it reacts by making more bone. And that's what bone spurs are, and that's what this little thing down here is. That's a bone spur that's forming because of the bone on bone and the bones reacting to the extra stress by making extra bone. And the extra bone bumps into each other, and that leads to stiffness and more pain. So arthritis that affects the AC joint up on top, again, anti-inflammatories, cortisone. I don't find physical therapy particularly helpful for this. I find cortisone injections very helpful for arthritis of the AC joint. And then surgery. And what the surgery is, in this case, we resect the end of the clavicle so the two bones don't rub against each other. The clavicle in this video is to the left. The acromion is to the right, and the shaver is being brought in to shave off the end of the clavicle. There's 3 ways that we will deal with arthritis of any joint. If you get arthritis in the fingers, we will oftentimes fuse the joints, and that's actually the most reliable treatment. We'll actually cause the two bones to heal together and become one solid bone, and they no longer move. You've lost range of motion, which is okay in the tips of your fingers and stuff like that, and it gives you a painless finger. Another way we'll deal with arthritis is we will cut off the end of one of the bones, what's called an excisional arthroplasty. It leads to somewhat of a floppy joint, but in the AC joint you have enough ligaments to stabilize things. But excising the end, the top of the humerus or one of the knee bones or the hip would not be conducive to function. You couldn't walk if we cut off the end of your thigh bone or top of your thigh bone. So that's why the larger joints get replacements, which we'll talk to in a second. So here we are finishing up excising the end of the clavicle. And I usually put a needle in to make sure that my resection is symmetric and I haven't left any bone. And I can measure the distance between the needles to make sure that I've resected the proper amount. So when it involves the shoulder joint, non-steroidals, again, cortisone injections, physical therapy to try to keep the shoulder as flexible as possible. Hyaluronic acid injections like Synvisc are used in the knee. It has not been shown to be beneficial in the shoulder, so insurance companies will not pay for it in the shoulder. Synvisc is a viscous, slippery fluid made of hyaluronic acid, which is found in high quantity in normal joint fluid. And scientists said, what if we inject this normal molecule into people with early arthritis in the knee? And lo and behold, as a doctor or a surgeon, I found quite a few patients say it helps. Insurance will pay for it every 6 months. And so patients will come and say, can I get another Synvisc injection or Hyligan injection? There's lots of different brands out there, Suparts, Uflexa, Orthovisc. Can I get another injection of this hyaluronic acid into my knee every 6 months? And insurance will pay for it. Insurance, no surprise, led by Anthem, is paying for it less and less. In fact, in Massachusetts, Anthem is no longer paying for these injections in the knee. They still are up here, but we feel it's a matter of time. In the shoulder, it's never been proven to be beneficial, so no insurance will pay for it in any state that I know of. So what that means, if you want to try it, that's fine. They will pay for me injecting it into you, but you just have to go to the pharmacy and pick it up yourself. And I'm not sure how much it costs, but it's not.
What's their justification?
No proof that it works. And then resurfacing is what the surgery is. Many times when people get knee replacements, hip replacements, or talk about that, they're like, oh, I don't want that. That's going to be a disaster. You know, you kind of have this envision that you're going to be the $6 million man, that we're taking out the whole muscle, bones, nerves, and everything and throwing it away and putting all we're doing is resurfacing the bones. We are leaving the muscles, we're leaving the nerves. All we're doing is just so that you don't end up bone on bone. We're resurfacing the ends of the bones. So this is what it is. On one side, you end up with plastic, a high-grade medical plastic called polyethylene. And on the right side, you end up with a polished cobalt chrome surface. And this is exactly what's in the knee and in the hip. It's polished cobalt chrome against polyethylene. Here's an example of an arthritic bone-on-bone shoulder, and this is what it looks like after a shoulder replacement. The space between the ball and the scapula is filled with that plastic. So the ball is up against the plastic. This is a special situation. This is an arthritic shoulder. You can maybe tell the difference between these two shoulders. This shoulder has a normal rotator cuff. Notice the ball is centered on the socket. After the shoulder replacement, the rotator cuff is still working. But in this situation right here, we have arthritis bone on bone, but the rotator cuff is not working. And the arm is up high. So if I did a shoulder replacement in this situation, and I have definitely, the next picture is not mine, but I have definitely done shoulder replacements in patients who I thought had good rotator cuffs, and then within a year or two down the line, their rotator cuffs failed, and they ended up in a very similar situation. So this is something for my fellowship, but this is an example of why shoulder replacements cannot work. And I would say definitely in the, prior to 2005, when the reverse shoulder replacement came to this country, there were many people who had shoulder replacements that did not do well. And it's because of the rotator cuff, because they ended up in this situation. They would have a shoulder replacement, they couldn't lift up their arm. And we think now that we can help a lot of those people with a solution called the reverse shoulder replacement. And what it does is it's plastic against polished chrome, but we reverse it. We put the ball on the socket side and the socket on the ball side. So on the left we have arthritis with a normal rotator cuff. We have a nice space for the rotator cuff. The ball is centered on the socket. On the right, the rotator cuff is torn. The humerus is high riding. The one on the left gets a regular shoulder replacement with the ball on the humeral side, and the one on the right, we reverse it. We put the ball on the shoulder blade side, and we put the socket on the humerus. And what that does is the ball and socket, it pushes the arm down. Instead of, if this is the socket, instead of having the arm up high, by putting the ball on this side, it pushes the arm down. It turns into more like a hip joint. So now we're pushing the arm down, the deltoid is under tension, and when the deltoid fires, it will pivot around the ball instead of sliding up out of the socket. And it's a procedure that nobody gets 100% results, but it is a procedure I enjoy doing for people who are miserable because I can make people happy. And these are some examples. These people allowed me to give their videos. I said, just show the audience how miserable you are. You can see kind of the show. And then after a reverse, so that's before a reverse, so he had arthritis and a large, massive rotator cuff tear. And this is afterwards. He thinks he can even pitch. One more time with the pitch. And this is a lady who I already did a shoulder replacement, a regular one on her left shoulder, which had a normal rotator cuff, but her right shoulder, the rotator cuff was torn. So this is before her surgery on the right, but after surgery on the left. And obviously, I'm showing you videos of success, great success stories and stuff like that, but this just gives you a little bit of an example.
Did she have a genetic propensity?
Yeah, because she's relatively young with arthritis in both shoulders. And I think that's the most common thing. When people say, why do I get arthritis? I usually say, blame your parents. That's what she ended up on the right side, and that's what she ends up on the left side. That was the regular shoulder replacement on the left. And this is her after both surgeries. So how do you avoid arthritis? Often you cannot. It's usually related to how you're born. Seek help before it's too late. And what I mean by that is, I don't know, it kind of goes a little bit against my philosophy. When I do the surgery, I have to put metal and plastic into the shoulder. I've had a couple of cases, particularly in rheumatoid arthritic patients, where the bone is so eroded, there's nothing that can be done. So if it hurts, it's maybe not unreasonable to come by, get an x-ray, and say, yeah, you can live with it. Come back in a couple of years, we can repeat x-rays just to make sure the bone hasn't eroded. Biceps tendon disease. The biceps can often be torn. So this is an arthritic shoulder. You'll see a little bit of the loss of cartilage on the ball. You'll see a little view here where the probe's kind of pointing right to the bone. So the cartilage is worn away pretty much right down to bone. The cartilage is usually about 3 millimeters thick. Here you can see it's down to bone, or maybe a millimeter left in that section. And then looking at the biceps tendon, you can see when I pull the biceps, there's a tear in the biceps tendon, and that will cause people to have pain in the front of the arm right along the biceps. And that is something that the biceps is not a rotator cuff. It is not important for the function. So usually when people have tears like this, I tell them to live with it as best as they can. I might give a cortisone injection. It does not lead to arthritis. Oftentimes that partial tear will rupture on its own, and people will say, oh, they get black and blue, and then they notice a day or two later that their pain's gone because they've just ruptured the biceps tendon, and that's a perfectly reasonable thing. Two athletes that are famous, one is Brett Favre, who was a quarterback for the Jets. He was having problems. biceps pain, they cut the biceps. That's all they did. They went in there and they cut it. His pain went away. He kept playing for the Minnesota Vikings for a couple years. The other is Kurt Schilling. He had surgery that I typically do. They went in there and they cut the biceps tendon and they reattached it. And I tend to reattach it because if you cut it and you just let it fly, you can end up with a little bump in the arm down here. And I just don't want my patients going to the beach and saying, "Why is your arm looking funny?" and then having people say, "Oh, it's because Noerdlinger did that." So I tend to reattach it. It takes me about 15 minutes to do, just so the arm looks symmetric, but there's really no other reason to do it. Sometimes when you don't reattach it and you get a bump, people will end up with a little cramping in the biceps. The biceps really functions just at the elbow. It has no real shoulder related. So I will operate if it's, if people say I can feel it snapping in and out of the groove, if there's tendinitis that doesn't get better with cortisone, time, or physical therapy. If people rupture their biceps, I've had 1 or 2 patients say, "I ruptured it, I know I don't need to get it fixed, but I don't like the lump, can you fix it?" And a slap tear, which again is another talk about instability, but the slap refers to the labrum, and the labrum up on top is called the superior labrum. And this is where the biceps is coming in and attaching onto the socket. And when I lift up the labrum up on top, you can see where it's detached, and then I sew the labrum back down. That's a slap repair, which is another way of dealing with people with biceps problems. And then the final thing to talk about are fractures, or I guess this is the penultimate thing to talk about. Most fractures around the shoulder can be treated non-operatively. The ones that are broken and shifted out of position are usually treated with surgery because we sense that if the bone's out of position, it may not heal, or it may not heal properly, or may lead to arthritis down the line. So a couple ways that we fix shoulder fractures. If they need surgery, this is with plates and screws. I'm sorry, I'm getting a... so on the left, you can appreciate the fracture, and on the right, the fracture's been put back together with plate and screws. Sometimes the fractures are so bad or the patient's bone quality is so poor that plates and screws won't hold. And in that situation, knowing that the rotator cuff attaches to the top of the arm, knowing that this person's rotator cuff is probably not in a good shape, doing a shoulder replacement because of bad rotator cuff tendons, doing a reverse shoulder replacement is the best thing to do. What's new in the future is things that are coming down are biologics, and I'm going to be starting to inject growth factors into my repairs. It's starting to be done using amniotic fluid, which has lots of growth factors. This is fluid taken from volunteer moms. It's not from any aborted fetuses, just from normal pregnancies. It's all tested. It's implanted. The fluid is injected at the end of the procedure. It seems to help, some people believe, the rotator cuff tendon healing to the bone. It prevents stiffness after surgery. And also, there's some arguments because of the growth factors have this role of decreasing the risk of infection. And just to let you all know, that's the end.